Awesome. Well, thank you so much, Dr. Lamar. Love to see the collaboration with Dr. Rubin and also with Guy Weinberg. Dr. Lamar, if you could please send a sincere thank you to Ryan and the rest of the lab from the EHE community, we would truly appreciate it. And I know I can speak to say we are very thankful that we are testing these things on mice rather than patients. So thank you. So next up are two speakers that will be presenting on exploring the genomic landscape of epithelioid hemangioendothelioma. The first speaker is near and dear to my heart, Dr. Chen, who is with the Ohio State University Comprehensive Cancer Center. He's also my personal oncologist, so he has to deal with me often, and I appreciate the heck out of him. The second speaker is Nathan Seligson. Nathan comes to us from the University of Florida as clinical assistant professor, and we are excited to hear about this topic. So please welcome Nathan and Dr. Chen.
Perfect. Hey, Jenny, thank you. On behalf of Nathan and myself, we wanted to thank the EHE Foundation. We're honored and feel very privileged to be able to present our findings to such a esteemed audience here. And we're going to come a little bit full circle from the talks that came up earlier today. So I think it's a kind of a nice way to wrap up before the lunch break, or hopefully it's a lunch break, and give us a little bit of time there. And but as Dr. Tapp was talking about, there are a lot of drugs, right, that are coming on right now, and different things for different people. And a lot of these are anecdotal. We don't have a good way of kind of thinking about it necessarily, and not a good way of analyzing the data. Dr. Antonescu gave us great clinical features of these tumors that help us subset kind of in terms of their aggressiveness. But obviously in 2021, everybody is talking about molecular testing, but what do we really know about that? And that's really what kind of sparked our interest in looking at what is really the genomic landscape of EHE. Can we glean something from the molecular profiling of these tumors? Next slide, please. And so I'm not going to really belabor some of this because we've talked about this ad nauseum at this point here, but really the clinical course is unpredictable. A lot of times the traditional thought is, you might just watch it, right? Surveillance, or do you do something very, very aggressive? Do you try to do a large scale resection? And as I mentioned, we heard a lot about the risk factors. And so that kind of brought us to, next slide, please. To looking at what are the molecular markers. Part of what our lab focuses on at OSU is really looking at data integration and data harmonization across multiple data sets. That's kind of what a lot of our sarcoma research is really based on, is how do we take disparate data sets, merge them together, and perform analyses to find the right drug for the right patient at the right time. That is kind of critical. And we're looking for new drugs, which are always helpful, but what about all those old drugs that help for a percentage of patients? Wouldn't it be nice if for a new EHE patient, we could figure out which drug should go with which person, right? It doesn't have to be new and novel. It could be an older drug that just works well. So that's kind of the background here. But in order to do that, we need to really have a grasp of what that landscape looks like. And at this point, I'm going to turn this over to Nathan. Nathan was in our lab. He's actually a cancer pharmacist, if you can believe it, who rotated through our lab to do a physician oncology fellowship, and extraordinarily brilliant. And he did the bulk of the analysis here, so I thought it was only right that he present the results. So Nathan, it's all yours.
Thank you, Jim. I appreciate it. Can you please go to the next slide? So the data that we'll be presenting today comes from a large multi-center cross-sectional retrospective study of the genomic features and landscape for patients with EHE. We were able to collect genomic data for 49 EHE patients out of a total of more than 10,000 sarcomas that were queried, again highlighting the rarity of this disease. 46 of those tumors with DNA sequencing came from the Foundation Medicine Research Database, The WWTR1 Campto-1 fusion was confirmed in these cases by RNA sequencing. 3 additional tumors came sequenced by OmniSeq. The fusion was not confirmed by sequencing in these cases. Additionally, we were able to collect clinical data for 14 participants through 4 individual clinical collaborating sites. Next slide, please. We included both pathogenic variants and variants of unknown significance in our analysis. These were determined by Foundation Medicine or by Cosmic for tumors sequenced by OmniSeq. Signaling pathways were then defined by superpaths, and targetable variants were defined by OncoKB classification. Next slide, please. Looking at our 45 individuals as a whole in terms of demographics, the mean age at diagnosis was just under 50 years of age. This data set leaned heavily towards female sex, with over 65% of individuals being female. What was interesting here is if we looked at the DNA sequencing for these samples, only around 40% of tumors sampled here exhibited the WWTR1 Campto-1 fusion as the only pathogenic genomic variant present in that sample. Next slide, please. This means that a majority of patients with EHE had tumors that exhibited a secondary pathogenic variant, or a variant in addition to that driving gene fusion. Looking at what these pathogenic variants were, it was primarily driven by alterations in CDKN2A and B. These variants were present in 6 of the tumors, representing 21% of tumors that had secondary genomic alterations. This is a fairly significant segment of the population here. Because alterations in genes outside of CDKN2A or B were sparse, we looked at these alterations from a pathway perspective. Next slide, please. Looking at the cell cycle regulation pathway, we included about 10 unique tumors, so greater than a third of the tumors that had a secondary pathogenic alteration had an alteration in a cell cycle regulation gene. And again, this was driven by the high prevalence of alterations in CDKN2A and B and RB1. And this is interesting and not inherently surprising given the prevalence of these alterations in sarcoma as a whole. Next slide, please. We know that the RB1 CDKN2A pathway is highly important to oncogenesis and clinical outcomes in sarcoma. Next slide. It's been linked to the development of sarcomas as a whole. Next slide. It's been linked to a loss of this pathway has been linked to a promotion of metastasis. Next slide. It's been highly correlated with prognosis in soft tissue sarcomas. Next slide. And alterations in these genes are actually highly frequent in fusion-driven sarcomas. In Ewing sarcoma, it represents the second most commonly altered secondary pathogenic variant at around 12%. In EWSR1 PATC1 fusion sarcomas, it represents about 70% of tumors having this CDKN2A loss or pathway loss. Next slide. In addition to losses in cell cycle control, we identified a number of alterations in DNA damage repair genes. Now, there have been previous reports suggesting that DNA repair inhibitors may be effective or may be of potential utility in EHE. We found, despite 25% of these tumors having alterations in DNA damage repair genes, variations were highly sporadic. The 2 most interesting would be an amplification in ATM and a nucleotide variant in BRCA1. Next slide. So from focusing from any pathogenic variant to those that would be most clinically actionable or targetable, we used OncoKB to classify the level of evidence and targetability of each of these genes. When we did that, while there were a number of genes that popped up on our radar, there was no obvious consistent target throughout the tumors that were included in this study. A few of these variants would be considered clinically actionable, where you would give a drug for these specific alterations. And most of these were on a patient-by-patient or tumor-by-tumor basis. What was interesting, next slide, is that the pathogenic variants that were considered targetable were highly correlated with an older age at diagnosis. So for those that were greater than 45 years of age at diagnosis, there was a much higher probability of having a secondary targetable genomic variant present in that tumor. Next slide. We then turned to the patients for whom that we had clinical data available. This included 14 subjects. Interestingly, we had 4 that had early stage disease, stage 1 or 2, and 10 with stage 3 or 4 advanced disease. We identified here is that those with advanced disease were older at diagnosis, again with a mean age of 54 years for those with stage 3-4 disease. Next slide. But even more interestingly, those with stage 3 or 4 disease almost exclusively had pathogenic variants secondary to the primary gene fusion present in that tumor, where those, at least in our very small clinical set here, with early stage disease not presenting any secondary pathogenic genomic variants. And this is interesting, suggesting that there's both a link to aging and potentially genomic complexity in the aggressiveness of tumors. Next slide. And I'll hand it over again to Jen for this portion.
So just to kind of take a 10,000-foot view of what we're trying to say here is it really as simple as this, that if you are a newly diagnosed EHE patient, if we undergo molecular testing, a lot of the FISH approaches are really just focused on looking for the fusion. But if we do a little bit more exhaustive search, looking for other oncogenic, other cancer-causing genes, and the Foundation Medicine assay that was the kind of the bulk of what we have here tests over 500 genes that do this, along with, as Dr. Antonescu had pointed out, there's also RNA sequencing that is performed. If we come up with additional ones, right, does that mean that patient should get more aggressive treatment because the tumor is more likely to be aggressive, right? Or on the flip side, if we don't see any additional oncogenic mutations or any sort of variation there, does this mean that the tumor is more quiescent and that surveillance may be a reasonable approach? These are things that obviously need to be borne out. I'd like to point out that one thing that we are currently looking at is really, and Nathan and I, we've published a different paper looking at another fusion variant, but looking at copy number of the fusion. And this was mentioned earlier by one of the other speakers. So obviously, how many copies of that CAMTA fusion seems to matter. We're still trying to work that out a little bit better. But is this a new paradigm for treatment? Is this something that we can take away now for just thinking about the disease and trying to do a risk stratification? Outside of the excellent, the clinical pathologic features such as mitotic rate that were talked about prior. Next slide, please. So as Nathan pointed out, it took us to search about 10,000 sarcoma patients to come up with a roughly 50. And in order for us to confirm these findings, and I love the question from the chat earlier about how many patients does it take to try to figure this stuff out. Dr. Tapp had mentioned 10 patients for particularly one drug, potentially, right, as a signal finding, right, if we're thinking about a phase 1 trial. But if you're thinking about trying to stratify patients across 4 different drugs, or, there's several drugs that work, it's not going to be a one-size-fits-all approach. Remember, we're trying to go for the right treatment for the right patient at the right time, right, at the right stage, if you want to think of it that way. You're going to need a lot more patients. And we searched 10,000 patients to get 50. So this is a perfect example where I think collaboration is essential. It's not just needed, it's essential to move the needle forward, because outside of that, there's no way we're going to get enough patients with enough collective experience to be able to know whether or not GemTax works, who should get trametinib, Should everybody get IO? These are all open questions. And as these trials come through, keep in mind that they're going to be small sets, right? So every patient that has EHE hopefully would be entered into, we would collect information such as this, right? You could imagine every patient here would potentially donate their stage at diagnosis and also what their molecular profile at diagnosis is. We sequence everybody, I believe MSK does too, everybody who comes in through our doors, and we find a way to pay for it. It's either through philanthropy or it's through a lot of the molecular profiling companies will do it. There's patient assistance. So I don't think there's any excuse for not getting molecular profiling at this day and age. I look at it as a standard of care, and I don't think we can do very much without it because we need to confirm the diagnosis. But more importantly, based on our findings here, I'm very, very interested in making sure that we understand what these secondary alterations look like. So next slide, please. So what does this mean? So after you kind of identify these, participants, can we build a registry? And there are many different efforts kind of ongoing right now. I can tell you that I head up one or two of those efforts, but EHE remains a very small percentage of that. So part of the strategy, and Jenny knows we've talked a little bit about this before, is that can we leverage large registries with very focused disease-specific registries to create a kind of a meta-registry of EHE patients, right? Can we do that? And that's been a big focus. And now we have the technology in place. There are enough institutions that have registries. The technology is not an issue. It's really just the logistics and getting everybody on board and getting the word out there. But this is the only way that I can see, and this is kind of a big plug for data sharing and also data harmonization, that we will be able to answer the question whether or not someone who has a CDKN2A loss or a CDKN2A mutation that Nathan spoke about so eloquently earlier is more likely to have aggressive disease? Or are these also the same patients? In different contexts, we've been looking at too whether or not this CDKN2A loss also predicts for sensitivity to certain other chemotherapy agents, right? So is this what makes patients sensitive to that? Because CDKN2A loss actually causes cell cycle acceleration. We've heard a lot about that earlier. Or does it have to do with the copy number, right? But are these the patients that would do better with something like a mitotic spindle inhibitor? Okay, so these are a lot of open questions, and they're not really answerable. We can answer some of them in lab, but as you imagine, we've talked about two models so far of YAP and CAMTA. But the issue is that it's really hard to create all the different models that you would need, right? To get the fusion, but also alter this gene and then alter that gene and then alter this other gene. You kind of want to explore it in the wild a little bit. And this is the only way so that I can think of that as actually the fastest way to kind of explore in the wild and get that data together. So this is a big plug for, again, I think this effort that I think is critical for getting more drugs to the right patients for EHE. Next slide, please. So what are our big conclusions here? So the number one thing is there is a world outside of the fusion that we think, based on our data here, that helps drive the disease. It is not the driver, obviously, that is the fusion itself, but this helps, it kind of regulates it. Is it fast? Is it slow? There's clearly some other factor there. And as Nathan mentioned, this is like many other sarcomas. The genes that were mutated or lost are very common for different sorts of sarcomas. And so EHE, although unique in how it gets started, it's not that unique in how it gets faster. So I think this is also a great time to look at other diseases that have secondary similar alterations and say, hey, what works for these folks? What can we learn from that environment? And again, that takes databases and that takes some clinical correlation, but that's a little light bulb there that we can hopefully leverage for more common, if sarcoma is ever common, diseases for the EHE world. And finally, the plug, as I said earlier, is that a larger studies or a comprehensive registry might help us understand whether or not our, these findings here that we've presented really hold water, and clinical practice should be changed. Should this be part of the guidelines? Next slide, please. So a big thank you, particularly to all our patients, for letting us learn from them. As I said, it takes thousands and thousands of patients to figure out some of these hopefully findings that I think get us where we need to be. And this data has been presented and published prior, so the link is there. But we're always happy to kind of reach out and speak with anybody that has any questions about this. Again, thank you very much again on behalf of Nathan and myself for this wonderful opportunity to speak with you. And we'll take any questions at this point.
All right, we had quite a few questions come in here. So let's start off with the first one here. A number of additional mutations you saw are genes known to influence TAS function or protein level. Is it possible to correlate some of these mutations with TAS-CAM protein levels in the tumors, or is the sample size you have too small to be able to understand those correlations?
That's a great question. So part of the issue is that these samples were often from FFPE. The protein levels may not be stable, and also these are all historical in nature. So these go back about a decade, if not more. So we don't have the samples on hand to go back and look at the protein levels. What the study that we're currently looking at right now, kind of what I had alluded to earlier, is that can we correlate the levels of the fusion itself with the mutations, and the levels of the fusion itself with clinical outcome for some of these patients. So that's another additional analysis that we haven't completed yet, but we're interested in looking into.
Excellent, thank you. Got another one here. I know that getting this variation data can entail in-depth genetic tests that is expensive and often not covered by insurance. The specific question, do you recommend that patients get this additional testing if at all possible?
So as I kind of mentioned earlier, I think for all my patients, I think it's actually 100%. Everybody who walks through the doors at the James gets molecular testing. There's no reason not to. There are always mechanisms, philanthropy, et cetera, for getting the molecular testing. So I would say if your oncologist or medical oncologist is not comfortable with it, they should reach out. And we can help them figure out a way, because I look at this as standard of care, and I don't think this should be something that is exorbitant. In fact, insurance companies these days, Foundation Medicine, for example, a lot of them are moving in this direction, is covered by Medicare. So if you have metastatic disease over a certain age, it's covered by insurance. So there's really no reason why people are not getting molecular testing, in my eyes.
Well, let me do a follow-on to that. I think there's two questions here that relate to that point. First, is there a single test out there, Foundation or Archer or anyone else, who sort of captures all of the genetic variation one would want to capture here? Or does one have to sort of piece together a number of different tests to get the right answers, or the full set of answers?
Yeah, so that's a kind of a tricky question, because each of these companies all have different testing platforms, and depending on which test for example, Foundation has one that doesn't necessarily capture the fusion. You have to order the right test. So the short answer is all of them have tests that capture the right molecular landscape, right, that we talked about here, that everything we had from the fusion to the secondary alterations are all there. But you have to know which one to order. And that's usually where, when we get referrals from the community, where I see things drop off a little bit. They ordered a simpler test that lacked, for example, the fusions, or lacked something else.
So when you're doing that yourself and trying to get the best answers, either for your research projects or for clinical care, how many tests are you having to order to get that full story?
Just one.
Okay. And is that something you're doing in-house or outside of the university?
Actually, believe it or not, we send ours out because it's cheaper. We can do it in-house, but the in-house testing, we can do Archer panel, but I can't get that covered as easily as having the dirty little secret for a lot of these sequencing companies is that they do make money on the back end reselling data to pharmaceutical companies. So they are inspired and in fact want your data, because they can discount it heavily, right? And so it's a win-win for your patient. It's also a win-win for the sequencing company. So at OSU, that's harder to do, and so we can do that for some patients, but not everybody can do that. So as I said, there are many different ways, and we've been finagling this since all these panels came on the market.
Got it. And I got a question here asking about your personal clinical experience, which is for patients that you've been seeing where you've got identified potentially actionable mutations. Have any of those been exploited in your clinical practice where you've gotten a positive outcome?
So that's a great question. So the slide that Nathan showed there, you can see a lot of the secondary alterations that are actionable really don't have direct drug targets. Although P16, the CDKN2A, 2B loss is very common, or RB loss, these currently don't have readily available drug targets. So the short answer, unfortunately, is no. But I think that they may denote chemotherapy sensitivity, but that's going to need to be borne out in larger studies. I am very hopeful that we can figure out, for example, who are the better MEK inhibitor patients, who are the better IO patients, who are these people, and is it, obviously the DNA is not going to be the whole story. The stromal immune environment, the tumor infiltration that Dr. Antonescu and a couple other speakers were alluding to is going to be key. So I think this is just the tip of the iceberg. This is just getting us to knowing a little bit more about what the genomic subsets look like, but there are other ways of kind of slicing and dicing.
Got it. And then from in any of the samples that you've tested, do you have situations where you have earlier samples from those same patients where you can see if sort of one of these variations is preceding the other, maybe or any feel of whether any of these might be causative of the other, or if they're independent genetic events?
So I think the short answer to that is we don't have enough data to do that. But if you look at looking at the slide where Nathan had showed the indolent or the stage 1-2 versus 3-4, you can see the 1-2 tended not to have any alterations. So you may believe that the alterations are going to be a later event that may drive a more aggressive disease. We generally did not see, and if we look at that heat map, I don't know if we can, well, it's okay, we don't need to jump back. You can look at the slides, but if you look at it, you can notice that most patients did not have more than 1 or 2 alterations. So to that questioner's point, we don't really see this progression from one to another because usually these alterations are singletons, and we're not getting like this, one. If you think of a melanoma or some other cancer that has driven by, one mutation after another, well, all these already have the fusion, so they already have that first hit driving the car forward, and now all they need is another gene to kind of take out the steering or something like that, if you want to think of it that way. So that looks like it's sufficient.
Got it. And we've got a specific clinical question here. So do you recommend taking Celebrex 200 milligrams twice a day for preventing inflammation? Are there any long-term effects of taking it? And just the attorney in me is going to put in a disclaimer here that none of the speakers here are going to give medical advice to individual patients. You need to consult your own physicians for care, but any thought about sort of anti-inflammatories based on what you've learned as part of the process here?
So I'll just say, just very globally, that inflammation is generally bad, and for many tumors, and let me just use desmoid as a sarcoma example. Celebrex is a standard of care for treatment for desmoid tumors. It's being studied for other things as well. They've been looking at that for like colon cancer and other things that have an inflammatory component. So it would not surprise me that it may, again, I don't think these effects are going to be huge, but I think can you get a cocktail together that reduces inflammation, targets the tumor itself, and does different things to try to make it a more favorable environment for the immune system to keep the tumor under control. I think that still remains to be borne out.
Got it. In terms of the data you've analyzed where we've got patients with multiple of these markers that are potentially disease causative, do you have any feeling for the importance of the fusion relative to the importance of things getting expressed by mutation? Anything falling out of the data in terms of relative importance of each of these to disease contribution?
So I think the elephant in the room is always going to be the fusion. There's a lot more, and I really appreciate the speakers prior to us that really are drilling down and understanding what does that fusion really mean. So that is the driver. Everything else is kind of causing additional havoc and chaos. So what we've really analyzed is that secondary part, is that after the wheels have fallen off, what else is kind of making things go a little bit haywire. So the fusion is definitely the first most important thing. And if you get something that can target the fusion, obviously that's going to be key. Additional medications may help right the ship, as it were, change it from an aggressive back to an indolent form, because without those secondary alterations, if you believe that model, it may not be as aggressive. So you may be able to coexist with it rather than kind of be fighting it as much. So first the fusion and then the secondary alterations. But with that being said, though, drug development could develop, or if there are ones that are easily ported from different diseases, could be used to look at those secondary alterations, which we think are kind of that additional factor that causing problems.
Excellent. Well, that's all of the questions that have come in. Thank you so much for your time and for this important work.
Thank you.
All right. Well, thank you so much, Dr. Chen and Nathan. So what I'm hearing is that data is really important. So for all of the patients and the caregivers online today and listening, here's our plug. If you're having a procedure, please consider providing tissue for research, and consider having the additional testing done. And I will tell you, we have a great group of EHE foundations that can help and support you in that process. So again, thank you, Nathan and Dr. Chen, so much for being here. We appreciate your commitment to EHE research.